Hello, in MOGAD, I will be talking about the different types of pain associated with demyelination and how they affect the body. MOGAD, myelin oligodendrocyte glycoprotein antibody-associated disease, belongs to the same disease spectrum as MOG-associated encephalitis, transverse myelitis, and neuromyelitis optica. However, the symptoms differ significantly because the affected anatomical regions and types of immune responses vary. Let's explore these types of pain together and understand how they differ. One of the most frequent and noticeable symptoms in MOGAD is optic neuritis. This refers to inflammation of the optic nerve located at the back of the eye. The inflammation causes the nerve to swell and become damaged. Pain usually starts in one eye, but in some cases it can affect both. The pain tends to worsen when the eye is moved, as the inflamed nerve is strained during movement. Target area. The optic nerve carries visual information from the retina at the back of the eye to the visual processing centers in the brain. In MOGAD, demyelination begins in this area, disrupting signal transmission and leading to various visual problems. In some patients, an eye exam may reveal swelling of the optic disc, papillitis. Additionally, MRI imaging can show inflammation around the optic nerve. Common symptoms include sharp pain starting behind the eye and spreading to the forehead and temples, burning or stabbing pain that increases with eye movement, blurry or darkened vision, colors appearing faded or washed out, flashes of bright white light, photopsia, sudden or rapidly progressing vision loss, prognosis. In many cases, especially in younger individuals experiencing their first episode, vision tends to recover significantly within weeks to months. Up to 90% of patients show noticeable improvement. Even if vision doesn't return completely to normal, most patients regain their ability to function in daily life. However, optic neuritis related to MOGAD can recur, and with each new attack, there is a greater risk of permanent damage to the optic nerve. That's why early diagnosis and timely treatment are crucial for protecting long-term vision. This presentation is termed ADEM-like because the symptoms resemble those seen in acute disseminated encephalomyelitis. In MOGAD-related encephalitis, inflammation can affect not only the cerebral cortex but also deeper brain structures. This widespread brain inflammation often resembles ADEM in children, presenting with diffuse neurological symptoms. In adults, however, the clinical presentation can be more variable. For example, fever may not always be prominent. Instead, symptoms such as altered consciousness, seizures, behavioral changes, and signs of increased intracranial pressure may occur. In adults, encephalitis may also begin more insidiously, with neurological findings that are more focal or localized. Because of this variability, delayed diagnosis and treatment can increase the risk of permanent neurological damage. Affected areas. The brainstem, which controls vital functions such as heart rate and breathing. The hypothalamus, which regulates neuroendocrine processes such as body temperature, hormonal balance, and sleep. The thalamus and basal ganglia, involved in sensory and motor control. The white matter, crucial for signal transmission within the brain. The corpus callosum, which connects the two hemispheres of the brain, and the periventricular and subcortical regions, which play a key role in various cognitive and sensory functions. And in some cases, the meninges, the protective membranes covering the brain and spinal cord, may also be involved due to inflammation. Common symptoms: high fever and neck stiffness, widespread brain inflammation and edema, severe and persistent headache, confusion, agitation, and altered consciousness, balance issues and gait disturbances, double vision, speech difficulties, muscle stiffness or spasticity, insomnia. Cognitive and psychological impact. The demyelination in the brain can affect areas responsible for coordination, planning, and memory. Consequently, the psychological effects can be more profound compared to those seen in optic neuritis or transverse myelitis. MOGAD not only affects the eyes and brain, but also the spinal cord. This condition, known as transverse myelitis, is one of the most severe and disabling manifestations of the disease. Inflammation of the spinal cord often begins with pain in the lower back, upper back, or neck, and may radiate down to the legs. This pain can be sharp, pressure-like, or burning in nature. Target area: inflammation in MOGAD typically involves the thoracic, cervical, and less commonly, the lumbar segments of the spinal cord in a transverse pattern. However, MOGAD-associated myelitis also frequently spreads longitudinally, a pattern known as longitudinally extensive transverse myelitis, characterized by lesions extending across 3 or more consecutive spinal segments. This pattern helps differentiate MOGAD from other demyelinating diseases, particularly multiple sclerosis, which usually presents with shorter focal spinal cord lesions. Common symptoms include persistent back and spinal pain, even at rest, pain, swelling, numbness, and tingling in the legs, sensory loss or pins and needles sensations, difficulty walking and maintaining balance, urinary or fecal incontinence or retention, numbness and pain in the perineal area, known as saddle anesthesia. Inflammation in the spinal cord slows down or disrupts nerve transmission. This not only causes pain, but also leads to muscle weakness. The pain may be neuropathic, characterized by burning or electric shock-like sensations due to direct nerve involvement. In MOGAD, spinal cord inflammation can sometimes be monophasic, but many patients experience relapsing episodes. Therefore, long-term monitoring and early immunosuppressive treatment are crucial to reduce the risk of recurrence and prevent permanent disability. If left untreated, pain can become chronic and significantly impair mobility and daily functioning. MOGAD is mainly known for optic neuritis, transverse myelitis, and encephalitis. However, some patients experience additional symptoms or have other autoimmune diseases alongside MOGAD. Some patients have reported connective tissue diseases like rheumatoid arthritis, either diagnosed before or after MOGAD onset. This suggests that the immune system may mistakenly target multiple autoantigens. Although MOGAD is not typically classified as a systemic autoimmune disease, overlaps with conditions like RA can occur. Such systemic inflammation may disrupt immune regulation and increase the risk of central nervous system autoimmune disorders. Associated symptoms and conditions include rheumatoid arthritis, affects cartilage, bones, and joints, leading to deformities especially in the fingers, wrists, and knees. Hashimoto's thyroiditis, chronic fatigue, and a sensation of fullness or swelling in the neck due to thyroid inflammation. Sjögren's syndrome, persistent dry eyes and dry mouth caused by autoimmune attack on moisture-producing glands. Systemic lupus erythematosus. Butterfly-shaped facial rash and joint pain are hallmark signs of this systemic autoimmune disease. Epileptic seizures linked to cortical irritation, sudden uncontrolled electrical activity in the brain causing convulsions or sensory disturbances. Fibromyalgia, widespread musculoskeletal pain accompanied by fatigue, sleep disturbances, and cognitive fog. Migraine-like attacks. Recurrent throbbing headaches often accompanied by nausea, visual aura, or light sensitivity. While these are not part of MOGAD's classic triad, they may represent additional neurological effects and should be considered during diagnosis and treatment. As the MOGAD Solidarity Foundation, we will continue to share the latest reported symptoms related to updated MOGAD diagnoses. If you're experiencing different or unexpected symptoms, please don't hesitate to let us know. Every experience helps shed light for others.